Hello, a very good evening. Today, I'm going to talk about antithrombotic therapy during the COVID-19 pandemic. Well, you all know that we are facing this tremendous problem of COVID-19 disease since the first case reported in December 9 in 2019 from China, Wuhan. And since then, millions of patients have been diagnosed with the COVID-19 disease. A large number of patients has lost their lives due to several complications of COVID-19. Initially, we thought about that the disease itself manifests with several long complications that leading to ARDS, acute respiratory distress syndrome. But as the time went by, we did understand the basic pathophysiologic mechanism behind such mortality. We now understand that basically the complication is due to complication in the pulmonary vasculature, vasculopathy, be it in the arterial system or in the venous system. And ultimately, here lies the importance of giving anticoagulation therapy, antithrombotic therapy in such patients who have been diagnosed with COVID-19. And that's why today we're going to discuss about the importance of giving antithrombotic therapy, anticoagulation therapy in patients with COVID-19 disease. So without wasting time, I'm going to discuss in short about all these things. I'm going to discuss in 10 points. First of all, uh, I'll talking about prevalence of venous thromboembolism. Second point is anticoagulation for whom? Do we need to anticoagulate everyone? Number three is what will be the choice of anticoagulation? Will it be heparin and what will be the doses? Number four is whether imaging study is required or not. Next, the role of antithrombotic in dreaded complications of DIC. Number six is role of antiplatelets, especially in population who underwent PCI, percutaneous coronary intervention. Number seven, post-discharge prophylaxis, that is very important. And eight, oral anticoagulation, role of any directly acting oral anticoagulant agents, the novel oral anticoagulant agents. Number nine, drug-drug interaction because patients are receiving so many drugs. And lastly, I will summarize the protocol of giving such anticoagulation therapy. So first of all, what is the prevalence of venous thromboembolism in patients who are suffering from COVID-19 disease? So there has been a lot of confusion regarding this because the initial study reported almost 60 to 70% prevalence in several of the studies initially reported from China and Italy. Later on, the study shows a little less prevalence. Maybe one of the reason is the more use of anticoagulation therapy in the latter study. I'll go to one study from Netherlands that was done with 184 patients who are suffering from severely affected COVID-19 patients. And they shows that in a cohort study of 198 patients who are hospitalized with COVID-19, 20% patients were diagnosed with VTE during their hospitalization. Specifically, 6.6% patients were diagnosed with pulmonary embolism, that is pretty high, with a proximal DVT 5.6% and distal DVT 0.5% with upper extremity involvement also. So it was found that VT was more common among those admitted to ICU compared with those hospitalized with general wards requirement. Therefore, whatever several studies says, the basic thing is that a large number of patients, approximately 20 to 20%, 20 to 20, 30% patients in several of the studies reported Europe, in Asia, that suffering from venous thromboembolism, and a large number of patients among them also developing the complications of pulmonary embolism and ultimately mortality. Therefore, here lies the importance of giving anticoagulation therapy in right time with the right dosage. So number second issue is that which investigations will you ask for in a COVID-19 patients who will be managed in a home isolation? I have categorized the disease infected patients in three categories. Number one is home isolation. Number two is hospital wards, the general wards. And number three is hospital ICU, intensive care monitoring. So what will be the investigation of choice? So patients who are in home isolation will not be needing any anticoagulation therapy provided their coagulation parameters is not deranged. In all patients who have been admitted to hospitals need to be an anticoagulation therapy. That is the guideline nowadays. And of course, the coagulation parameter will guide you to give which doses you will give, whether it will be a therapeutic range heparin or an intermittent dose heparin. That depends on your coagulation parameter, depends on the clinical situation, depends on the physician expertise and the institutional protocol. So the basic investigations we would like to recommend in these patients is uh, D-dimer value, prothrombin time, platelet count, fibrinogen. Actually, you have to advise the whole of the coagulation parameter, but these four are the most important which will guide you to initiate therapy. So if your D-dimer is markedly raised, prothrombin time is prolonged, platelet count is very low, and if fibrinogen is less than 2 gram per liter, then patient has to be admitted. Even if there is no other concerns, patient is not complaining of hypoxia because these patients are at risk of developing hypoxia due to pulmonary vasculopathy, and they should be treated accordingly the protocol. And if these parameters are not markedly raised and the parameters are within normal limits, then they can be managed in the home with regular follow-up. That is, if the D-dimer value in repeat sample is rising, then they need to be monitored. Otherwise, they're quite safe in home and they just need to be monitored. Number three issue is that what is the optimal dose of anticoagulation? Suppose a patient is admitted in hospital, you want to start anticoagulation therapy for as a prophylactic. So what will be the anticoagulation of choice and what will be the doses? So basically all admitted patients with COVID-19 symptoms, whether it's a low risk of embolism or high risk of embolism, they got to be on heparin therapy. If they're in low risk of thromboembolism, the D-dimer value more than 3, you can start with enoxaparin 1 mg per kg twice daily, and you have to perform a point of care of ultrasound. If it is possible, it is better to not to go for it to decrease the healthcare worker exposure unless and until it is absolutely needed. So you can go with enoxaparin 1 mg per kg twice daily. If your D-dimer value is less than 0.5, then enoxaparin 40 mg once daily. And if your D-dimer value is between these two, then you can go with 40 mg twice daily. Now, in those patients who are at high risk of thromboembolism and with manifestation of like labored breathing, increased respiratory rate, decreased oxygen saturation less than 90%, elevated CRP, rising D-dimer value in repeat sample, and elevated fibrinogen level, they should be admitted in intensive care unit, and there must be high degree of suspicion of development of pulmonary embolism. And if it is there, then you have to start a heparin drip as per institutional protocol. And the APTT may guide you to increase the doses and to continuous infusion of heparin. Otherwise, you can start with enoxaparin 1 mg per kg twice daily. And also, you have to look for other parameters. And also, you can start with injection fondaparinux. In some cases, in Europe, they have given fondaparinux up to 7.5 mg once daily. And of course, you have to monitor the renal function. If your creatinine clearance is more than 30, then you can go with these doses. Otherwise, you have to halve the doses, as I've just mentioned. So there must be a pragmatic approach in this therapy in these patients who will be needing heparin, and the proper doses and the proper institutional protocol must be followed. So when imaging studies should be performed, there is several questions of whether you go for imaging studies before starting heparin therapy. You want to look for any clot, any thrombus inside the leg vessels or not. It has been studied in several reports, several articles that the yield, positive yield of this ultrasound is very low. In 10 to 20% patients, it has been found to be associated with clot. However, up to 50 to 60% of patients, the swirling pattern, which is the precursor of formation of the clot, has been found. Therefore, it is now the protocol that you have to give an anticoagulation whether you went through ultrasonographic examination of your cup veins or not. Because whether or not you do have any clot or not, you are going to be suffering from this disease all of a sudden, and that's why the imaging investigation is not a mandatory before starting your anticoagulation therapy. So assessment of VT should incorporate multiple elements of the patient condition, interval history, physical examination, vital signs, and of course the clinical scenario is the most important one. And when possible, Imaging confirmation of suspected VT should be obtained to guide anticoagulation decision. While this may not be possible in all settings, use of limited compression ultrasound, single stopping once a clot is identified, may help to minimize the exposure risk to vascular laboratory staff. In other testings, decision may rely primarily on clinical evaluation and assessment of thrombotic versus bleeding risk. Number 5 is that how will you manage antithrombotic in a suspected or confirmed DIC in patients with COVID-19? So these are the few of the guidelines from ISSTM that for patients with moderate or severe COVID-19 and in DIC but without overt bleeding, prophylactic anticoagulation should be administered. For hospitalized patients with COVID-19 with suspected or confirmed DIC, sorry for the interruption. I was talking about the patients who had risk of developing DIC due to COVID-19 disease, and I was going through the guidelines. So for hospitalized patients with COVID-19 with suspected or confirmed DIC, routine therapeutic or intermediate dose parenteral anticoagulation with EFH or LMWH is indicated. For patients with moderate or severe COVID-19, on chronic therapeutic anticoagulation who develop suspected or confirmed DIC without overt bleeding, consider the indication for anticoagulation and the risk of bleeding should be weighed when making clinical decision regarding adjustment of discontinuation of anticoagulation therapy. And for patients with moderate or severe COVID-19 and an indication for DAPT, dual antiplatelet therapy, and with suspected or confirmed DIC without overt bleeding, it is reasonable to continue dual antiplatelet therapy if the platelet count is more than 50,000. Otherwise, it should be reduced to single antiplatelet therapy and should be discontinued when your platelet count is less than 25,000. So these are the few important points in such cases. Our next issue is there a role using antiplatelet agents in patients with COVID-19? That is one of the questions we are hearing a lot. So basically speaking, if you go by the potential pathophysiologic evaluation of the complications of COVID-19, then you'll find that the virus membrane interaction leading to virus replication, virus dissemination, going into endothelial dysfunction, platelet activation, later on release of several cytokines, diffuse alveolar damage, platelet consumption, coagulation factor depletion, all this plays a role in the development of pulmonary vasculopathy. And ultimately diffuse alveolar hemorrhage has been seen. And there has been concern of this increased bleeding with the use of antiplatelet therapy because the occurrence of diffuse alveolar hemorrhage may mix with the same pattern of the ARDS. Therefore, the use of DAPT, use of antiplatelet therapy in such patients is very much harmful. And antiplatelet therapy, however, may be given after percutaneous coronary intervention, as we all know, especially in a setting of acute coronary syndrome when your bleeding risk is less. It should be continued for at least 3 months in a setting of acute coronary syndrome. And after that, it is better to switch over to single antiplatelet therapy rather than giving dual antiplatelet therapy. Aspirin use before hospitalization, but not after hospitalization, has been seen to be associated with lower risk of developing this ARDS and mortality with patients with community acquired pneumonia. Although P2Y inhibitors reduce platelet leukocyte aggregates and platelet-derived pro-inflammatory cytokines, it has been seen that ticagrelor is very unique in having all the well-documented additional target of inhibition, this ENT1 pathway. Therefore, ticagrelor confers more potent anti-inflammatory properties by inhibiting these receptors, inhibiting this release of these cytokines, and clinical benefit of ticagrelor has been established. So expert consensus warrants taking proactive measures or stopping antiplatelet therapy in patients with a platelet count which is very low. And emerging evidence suggests that DAPT is an important aggravator factor for diffuse alveolar hemorrhage, which can be mistaken as pneumonia initially because of similarities in clinical manifestation. And given the high bleeding risk in patients with COVID-19, After PCI, shorter duration of DAPT may be beneficial in this population. And DAPT should not be discontinued, however, less than 3 months after PCI, especially when the clinical scenario was due to acute coronary syndrome. And after that, you may switch over to single antiplatelet therapy, and ticagrelor may play a very important role in such cases. Number 7 issue is should patients with confirmed COVID-19 patients should receive post-discharge prophylaxis. That is a very important issue because patients got admitted, then they receive the anticoagulant therapy, and whether they are going to take it for long when they will be discharged or not. That is a very important question, and it has been seen in several studies. One of the studies have shown that the giving post-discharge anticoagulation therapy for long may decrease the mortality. One of the study has shown that decreased mortality by 25% when it has been given for more than 6 weeks. However, at the same time, you have to remember that the increased risk of bleeding is also there. Therefore, those patients who have certain risk factors like atrial fibrillation, have a mechanical prosthetic heart valves, or any other reasons for taking anticoagulation, or those who were initially on anticoagulation should be continued on anticoagulation. Otherwise, it all depends on your adherence coagulant parameters and the clinical scenario, how dangerous it was, how aggravated it was to start any anticoagulation therapy post-discharge. We can sum up that that extended VTE prophylaxis is not necessary for all patients with COVID-19 who are being discharged from the hospital, and a multidisciplinary discussion occur at or near the time of discharge to determine if a patient has ongoing VTE risk factors may benefit from extended post-hospital VTE prophylaxis or not. And using a standardized patient selection approach is very much essential because they also need to understand continuation of this anticoagulation. And if post-discharge prophylaxis is deemed reasonable, then it is recommended to use an adequately studied and approvable agent such as betraxaban, rivaroxaban, or enoxaparin, and suggest the limiting the total duration as used in several clinical trials up to 42 days, not more than that, unless and until patient has a different clinical scenario where chronic or achronic anticoagulation therapy is needed. So number 8 is that are there any drug interaction of antiplatelet agents or any anticoagulants along with various investigational agents that are being used in the treatment of COVID-19? Yes, we know that the patients usually receives antiviral like lopinavir, ritonavir, also the remdesivir, tocilizumab, sarilumab, all are basically cytochrome 3A4 inhibitors and can increase the level of plasma level of anticoagulation and may increase the risk of bleeding. Therefore, it is very crucial to determine in which dose you are going to start. And also the baseline coagulation parameter remains deranged, LFT remains deranged. Therefore, before prescribing any such anticoagulation, you have to consider all these factors. Otherwise, the catastrophic bleeding may occur. Number 9 issue is that when should patients on chronic warfarin therapy be transitioned to DOAC, that is the newer oral acting agents in this setting of COVID-19. So before answering the question, this is a pretty important guideline that when the last 2 INR therapeutic in previous 30 to 60 days, or is the time in therapeutic range TTR is more than 70% in the last 2 to 3 months, if the answer is yes, then you can resume vitamin K antagonist, extend testing intervals for local protocols. If it is no, then the consider following options like INR monitoring, in-home INR self-testing, drive-through INR testing. Nowadays, we do have a technical support of measuring INR at home. However, it is very costly, and if it is not feasible, then you have to assess the risk, the Chatsworth score again. And if there is no contradiction of DOAC, you can start with the DOAC. The contradiction are the venivalvular, especially the rheumatic one, mechanical valves, APLS, pregnancy. Otherwise, you can continue. If it is there, then discontinue. That's the sum up of starting this newer oral acting agents. So thromboembolism and anticoagulant therapy during the COVID-19 pandemic interim clinical guidance from the Anticoagulation Forum is that anticoagulation use may be some So it is recommended that the anticoagulation clinics use standardized educational materials for the COVID-19 patients whenever we're going to start NOAC therapy. And baseline INR value, baseline coagulation parameters should be checked. We do also recommend that the patients who would not be eligible for NOAC therapy prior to the COVID-19 pandemic not to be switched to NOAC therapy during the COVID-19 pandemic. This includes, but it is not limited to, patients with mechanical heart valves, severe liver dysfunction, or combined renal dysfunction, and a several drug-drug interaction that precludes safe NOAC use. Ability to reliably obtain and take NOAC is another important consideration when assessing eligibility to switch on. It is also suggested that the clinics interested in transitioning patients from warfarin to NOAC therapy develop a standardized protocol to identify these eligible patients. And it is also suggested that the taking chronic oral anticoagulant in the outpatient setting be switched to shorter acting agents, specifically low molecular heparin or unfractionated heparin when initially hospitalized for COVID-19 in cases of clinical deterioration, changes in renal function, or need for invasive procedure. Therefore, these are the most important thing that you have to keep in mind. Lastly, I would like to summarize the protocol therapy for COVID-19 anticoagulation algorithm that has been taken from Mount Sinai Hospital. And we are also following this protocol in such patients for anticoagulation. So admitted patients with moderate or severe disease who are at high risk, like increased oxygen requirement, hypoxia, increased D-dimer value, increased creatinine, increased CRP. You can start these factors are negative. However, if there are increased risk, you can go with pulmonary embolism protocol that I've already told you regarding starting of injection heparin. To maintain APTT of 70 to 110, it differs with the institutional protocol. You can start with ultrasound to look for clot. If it is not possible, do continue the anticoagulation therapy. If the heparin therapy is not available, heparin drip therapy is not available, you can start with enoxaparin, 1 mg per kg twice daily. Some institution has also opted for TPA protocol, however, not been very successful. And if your creatinine clearance is more than 30 to 50, you can go with the full dose. If it is less, then you can decrease the dose. Apixaban, rivaroxaban, dabigatran, all can be used. It's not that one NOAC is better than other. However, you have to keep in mind the renal function, you have to keep in mind the renal function, liver function, and the basic pharmacokinetics of these drugs before switching on to NOAC therapy. You have to obtain a batter-up test, especially the total coagulation panel, and you have to monitor the platelet count in those patients who have been receiving the DAPT therapy so that you can switch over to single antiplatelet to reduce the risk of bleeding. And at the same time, you have to monitor each and every single parameter, especially the oxygen saturation, the D-dimer value, repeat D-dimer value, whether it's rising or not, fibrinogen level, platelet count, because all these factors will ultimately guide you whether you will continue with the anticoagulation antithrombotic or not. So this is why I conclude today's seminar. I hope it helps you. And if you do have any kind of questions regarding the management of these patients, you can ask me, you can email me. And my email is drsudevmukherjee100@gmail.com, and my phone number has been given to you. So feel free to ask any questions. I'll be happy to help you. Thank you. This is one that just recently came from one of the participants, that a 32 years female, history of low grade fever for 3 days, along with a body ache, headache, and myalgia with no comorbidities, pulse at 100 per minute, temperature 99.5, saturation 98%. Lab investigation is total count 4,500, DC 66, neutrophil, lymphocyte 30, monocyte 1, platelet 1.75 black, and SGPT 42, CRP 3.5. COVID-19 RT-PCR shows positive result, and chest X-ray is normal. So patient opted for home isolation. And would you recommend any additional thrombosis workup? Would you consider antithrombotic in heart? So The question is a very good one, and the answer is very also simple, because now we do understand that all patients do not require anticoagulation therapy, especially those patients who are in home isolations and have no symptom at all, and also coagulation parameter is normal. So to the second question, yes, I would recommend a coagulation parameter workup, because you never know when this patient is getting symptomatic. So if your coagulation parameter is okay, it is normal within baseline level, then just keep it up, continue monitoring, that's all. But if you feel symptomatic and if your coagulation parameter is deranged, then you should be admitted. That's my answer is. And if you're not symptomatic at all, but still your coagulation parameter is deranged, then you need to be monitored how deranged it is. If your D-dimer is more than 3 times, then it's better to be admitted and take anticoagulation prophylaxis. But if it is less than 0.5, it's totally normal, then nothing to be worried about. However, you need to be keep monitored properly. So that is the way we're going to manage these patients.